Good morning. Myself Dr. Dhruvini, Assistant Professor in Cardiac Anesthesia. As a part of continuous cardiac education, today I am presenting a topic on point of care of ultrasound in ICU, lung and abdominal ultrasounds. There are a common point of care ultrasound application for assessment of airway, breathing, circulation, abdomen, gastric and vascular. But today we focus on the point of care ultrasound for mainly lung and abdomen. Lung ultrasound is integral to perioperative and critical care management of patient. It offers non-invasive, rapid, easily repeatable diagnostic scan at bedside without need for transfer or exposure to repeated high level of radiation. Lung imaging with ultrasound can produce artifact as air, cause significant impedance. This easily identified artifact can assist in diagnosis of many common pathology. Various probe used for lung ultrasound are low frequency curvilinear probe 3 to 5 MHz. It's used for the comprehensive visualization with adequate resolution. High frequency linear probe 8 to 10 MHz. It improves the visualization of superficial structures such as pleura. Phase array probe 2 to 8 MHz to visualize between the rib space due to its smaller footprint, although image quality will be reduced. There are different zone used for the lung ultrasound, the left side zone and right side zone, anterior, lateral and posterior. This image showing the lung ultrasound points, 6 points protocol, probe position in mid-clavicular line, mid-axillary line and posterior axillary line correspond the lung field anterior superior, lateral, posterior inferior respectively. First, lung ultrasound finding confirm you are in correct position to look the Batwing sign. This ensures that you probe in the between two ribs. Overview of lung ultrasound. By assessment of the lung sliding, we diagnose the pneumothorax. At lung zone, we assess the A and B line for diagnosis of pneumonia, ARDS and pulmonary edema. At PLAS points, at the assessment of the lung base to diagnose the pleural effusion and pneumonia. And by assessment of diaphragmatic fraction, we decide the weaning and ventilation and diagnose the diaphragmatic paresis and paralysis. Normal lung mechanics are characterized by the lung sliding. It's described as movement of parietal and visceral pleura sliding each other at the pleural line. On M mode, it is appear as the seashore sign. It's meant that pleura and overlying structures appear as horizontal echogenic line due to motionless chest wall, and while underlying lung appear as the grainy and sandy appearance. On normal lung parenchymal will have A profile. A profile seen as regular repetitive horizontal reverberation artifact arise from the air below the pleural line, and when air is replaced with fluid, image will show B line which are commectal artifact, vertical hyperechoic line arising from pleural line, and it is a down all the way to the bottom of screen. And when the ratio of fluid to air content increase, number of B line is increase in lung zone, accordingly result in B profile pattern, and presence of B line rule out pneumothorax. In interstitial lung disease and pulmonary edema may be indicated by number and distribution of B line in each zone. The presence of lung point defined as appearance and disappearance of the lung slide with respiration at particular points is equivalent to on mode is a barcode sign. It's characteristic and pathognomic for pneumothorax. Point where the healthy sliding lung meets the absent sliding in pneumothorax refer as the lung points. This diagram showing the algorithm for diagnosis of pneumothorax using lung ultrasounds. If the lung sliding is absent, then go see the A lines. If A line is absent, then see the lung pulse. Lung pulse is a rhythmic pleural movement of pleura that is synchronized with heartbeat due to its transmission through the mediastinum and lung parenchyma. If the lung pulse is absent, then search for the lung points. Blue points. Blue points is indicated by placing forefinger excluding thumb of the left hand below the clavicle at patient's right side and having tip of finger over the sternum and upper point located at base of second finger and third finger. By placing the right hand immediately below the left, so the forefinger are next to each other, you will find the lower point in middle of the palm. Repeat the process on other side and find all four anterior blue point. Area covered by the hand correspond to location of the underlying lungs. Now, posterior lateral alveolar pleural syndrome, point indicated by intersection of the horizontal line at level of the lower blue points and vertical line at posterior axillary line. It's the lowest point in the lung that should be investigated with curvilinear probe to rule out the pleural effusion and the consolidation. The detection of the Plapp's points indicate the consolidation and the effusion at lung base, and absent indicate the other pathology at the lung base. Normal curtain sign, dynamic movement of the lung air which due to the expansion and retraction of the lung. Lung curtain move down and up covering various portion of upper abdomen and diaphragm. In presence of pleural effusion, the curtain sign is absent. Normally, there is a spine above the diaphragm is not visible, but if pleural effusion is present, spine visible through the fluid is referred to as spine sign. The probe held perpendicular to the skin surface with marker indicate cranial dilations. In case of the moderate to large pleural effusion, lung atelectasis may appear as vase-shaped mass known as jellyfish sign, and it is due to the shape and free movement in the effusion. A lung ultrasound is superior to the X-ray for detection of pleural effusion with sensitivity of 100% for effusion above the 100 ml and diagnosis accuracy of 93% in ARDS. Lung ultrasound can guide chest drain insertion and monitor resolution of pleural fluids. On M mode, pleural effusion sign appear as a sinusoid sign, sine wave. It's caused by parietal and visceral pleura moving closer and further apart while the patient breathes. White arrow indicate the visceral pleura and black arrow indicate the parietal pleura. Pleural effusion has a anoic appearance delineated by the pleural line, rib shadow and lung line called as the quad sign. If the pleural effusion due to the exudative fluid, then it appears as a swirling hyperechoic debris. It's known as a Plancon sign. Hematocrit sign is referred to the echogenic layering of material in pleural effusion. This is due to the exudative effusion or hemothorax. How to calculate the pleural effusion size? So, by measuring the distance in millimeter between the diaphragm and base of lung in supine position and multiply by 20. Alveolar injury from the pneumonia will typically produce the consolidation. In area of significant consolidation, lung may appear hepatitized, where the tissue appear as a solid and resemble the hepatic tissue. The pleural line is irregular with straight sign, signify the division between the aerated and consolidated lung. It may appear as if the chunk have been taken out of tissue. This figure showing the straight sign. Upper arrow indicate that the subpleural consolidation abute the pleural line and the lower border is a straight sign. In area of consolidation is large, then deeper border is not appreciated and consolidated lung appear as a tissue. It's continued of liver right side and spleen left side. A dynamic air bronchogram signify the consolidation and static air bronchogram indicate atelectasis. This ultrasound finding in selected pathology for lung parenchyma for diagnose different pathology. Blue protocol, basic lung ultrasound emergency protocol. First say the lung sliding. If present and B profile is there, then it diagnoses pulmonary edema. If the lung sliding is present with A profile, then go for sequential venous analysis. If the thrombus vein, then pulmonary embolism. If free vein, then go for the stage 3 Plapp's point. If positive, the diagnose the pneumonia. If negative, it's COPD and asthma. If lung slide absent or present or A and B or C profile, then it's a pneumonia. And lung sliding is abolized and B profile, there is a pneumonia. And a lung sliding is abolized and A profile with lung point, then it's diagnosis of the pneumothorax. And if lung slide is abolized, A profile and without lung point, then go for diagnostic other modality. This diagram showing the fluid administrations limited by lung sonography false protocol to rule out the obstructive shock, cardiogenic shock, hypovolemic shock, distributive shock with the blue protocols. Diaphragm ultrasound. This table showing the etiology for diaphragm dysfunction, surgical causes, intrathoracic pathology, malignant disease, neurological disease, myopathy and phrenic nerve injury. Diaphragm insertion is consist of cylindrical area around the lower rib cage known as zone of apposition, and diaphragm thickness is measured in this zone of apposition with linear or curvilinear probes. Diaphragm thickening fraction during the respiration can calculated with this formula: end inspiration thickness minus end expiratory thickness divided by end expiratory thickness. The normal thickness range of diaphragm 1.7 to plus or minus 0.2 millimeter in relaxed position and 4.5 to plus or minus 0.9 millimeter in during the maximum contraction. With this function, if this function is there, then thickening fraction is less than 30%. Diaphragmatic excursion can quantify from the right subcostal window that avoid the air-filled stomach. During the respiratory cycle, M-mode imaging can assess excursion which varies from the 1 to 2 cm in quiet breathing to 6 to 7 cm in deep breathing. Diaphragmatic scanning is optimal during the spontaneous ventilation. A negative excursion where diaphragm move away from transducer indicate paradoxical movement. It implies the degree of paralysis. Although there is some trial suggests that successful tracheal extubation is more likely when thickening fraction greater than the 30% with excursion greater than 10 mm. This image showing the ultrasound guided diaphragm scan with probe in mid-axillary line. Abdominal ultrasounds, a focal assessment with sonography in trauma fast examination done for detection of acute pathology in abdomen and pelvis, intra-abdominal bleeding, ascites, to diagnose the source of post-operative hypotension after abdominal procedure, free fluid within the abdominal cavity, hepatic congestion, obstructive nephropathy, sign of cholecystitis and retroperitoneal hematoma. The specificity of fast examination for detection of free fluid in abdomen and or pelvis is very high, at 86% to 100%. Despite this high specificity, it's a lower sensitivity, means that it should not be sole imaging modality to rule out the free fluid. A positive fast examination indicate that the patient has at least 300 to 500 ml of free fluid in peritoneal space that frequently indicate ongoing hemorrhage after abdominal and pelvic procedure. This figure showing the probe placement for the fast examination with marker orientations. In probe placement for the right upper quadrant to see the hepatorenal recess Morrison pouch between the liver and kidney. This figure showing the left upper quadrant marker evaluation to diagnose the free fluid in perisplenic space between the spleen and kidney and spleen and the diaphragm to diagnose the free fluid in subphrenic and splenorenal space. This figure showing the collection, free fluid collection perisplenic space. This figure showing the pelvic probe placement for pelvic longitudinal evaluation with orientation marker. In first figure B showing the male sonoanatomy in which the rectovesical space located posteriorly, and in case of female there is a rectouterine pouch of Douglas is located posteriorly behind the uterus. This probe placement pelvic for transverse view to diagnose the collection in pouch of Douglas and rectovesical space. Gastric ultrasound. It provides the qualitative and quantitative assessment of gastric content, aid in formulation of safe anesthetic airway management to plan the minimize the aspiration risks. This figure showing the right lateral position for gastric sand using the curvilinear probes. The stomach is considered full if has a solid content and if the liquid volume is greater than 1.5 ml per kg in right lateral position. If antrum is contain carbonated fluid, then it appear distended with the hypoechoic fluid and hyperechoic spots. It's known as Sterry-Knight pattern. Gastric ultrasound has limitation in patient with previous gastric bypass, large hernia, hiatal hernia or previous fundoplication. If the whole stomach contain the liquid, then measure gastric antral cross-sectional area measure. If the gastric ultrasound with patient with solid content. Gastric antrum contain the solid. Its appearance is hyperechoic with frosted glass pattern. Gastric ultrasound, this figure showing gastric ultrasound in patient with empty stomach. Appearance of antrum is described as the bull's eye target pattern. These are reference. Thank you.